So I just came from Presidential Symposium 1 at ESMO, and I must say that this was one of the most uplifting lung cancer session I've attended, perhaps in my career. My career started when we used to see negative study after negative study, but today there were 3 presentations, and all 3 are potentially practice-changing. First one was immunotherapy after chemoradiotherapy for stage 3 inoperable non-small cell lung cancer. And as we know, with radiotherapy alone, these patients had a overall survival of about 10 months. With the addition of chemotherapy, sequentially, it became about 14 months. With concurrent chemoradiotherapy, it became 17 to 18 months. And now we saw in this study a randomization to placebo or darolutamide, which is anti-PD-1 monoclonal antibody, the likes of which we are already using in lung cancer, such as nivolumab and pembrolizumab. And this was a 2-to-1 randomization with about 700 plus patients randomized, and there was a 12-month difference in PFS. Overall survival is not mature yet, so I think this is going to become a new standard treatment for stage 3 inoperable lung cancer. For these patients, we had made no progress in a couple of decades. The second was a randomized trial, but not about treatment. It was about surveillance. We have guidelines in United States, NCCN guidelines state that after curative surgery, lung cancer patients should be followed every 6 to 12 months with a CT scan. Some of us do it more frequently, but no one wants to do it less frequently, but there's been no randomized data what to do. And this study randomly assigned more than 1,700 patients to either chest X-ray or CT scan of the chest with contrast in these 2 arms. They were randomized 1-to-1, and they were seen every 6 months with a physical exam and history for the first 2 years, but either had an X-ray or a CT scan with contrast. After first 2 years, they were seen annually. The results were interesting. There was no survival difference with 8+ years of follow-up. However, patients who had the CT scans had shorter disease-free survival, and we would expect that because CT is better at detecting metastatic disease, but it did not translate into better survival. The other interesting thing was that there weren't that many new primaries, which would be the real reason to do the CT scan in the first 2 years. So the conclusion of the study could be that for 2 years, we should perhaps do no imaging, and after that, since these are high-risk patients, do an annual spiral CT like we do in high-risk populations for screening. The third study was targeted therapy in EGFR positive patients. As we know, we had first-generation tyrosine kinase inhibitors, erlotinib, gefitinib, which have about a 10-month progression-free survival. Then we had second-generation, afatinib is in the market, but dacomitinib is not. And dacomitinib recently had a randomized trial presented at ASCO, where it performed better than first-generation tyrosine kinase inhibitors, but with more toxicity. This study took osimertinib, which is currently in the market for patients who have T790M mutation. That's the only FDA-approved indication after failure on first-line TKI, but only if you have T790M mutation, which more than half the patients have. This study did a 1-to-1 randomization of more than 400 patients, and results were astounding. You saw, again, the projected 10+ month PFS as predicted with first-line TKIs, i.e. gefitinib or erlotinib, and gefitinib was given to 2/3 of the patients in that arm, and erlotinib to 1/3. But the competitor, the new arm, or the experimental arm, I should say, with osimertinib, had 19-month progression-free survival. So this is a real advance, not only because it was more efficacious, but when you looked at the toxicities, grade 3-4 toxicities with osimertinib were much lower than first-generation TKIs. For example, grade 3 or greater rash was seen only in 2% of patients. So I think that that's a clear winner as well. So there you have it, 3 trials. First one telling us to add immunotherapy after chemoradiotherapy for stage 3 inoperable patients. The second one asking us to back away from that many CAT scans in patients who are resected for cure. And the third one illustrating the benefit of using osimertinib upfront rather than saving it for second line, although I must add caution that we don't know what the sequence of second generation TKIs or first generation for that matter would show after osimertinib, and what would be the total area under the curve or the total survival of these patients by one approach or the other. That's an unanswered question. Thank you very much for your attention.